Okay. Well, good afternoon, everyone, and welcome to today's Epicenter Psychosis Speaker Series. I am delighted to introduce this week's speaker, Dr. Alice Medalia. Dr. Medalia is a professor of psychology at Columbia University Medical Center and the clinical director for cognitive health services for the Office of Mental Health for the state of New York here. As many of you already know, she is one of the absolute preeminent scholars and clinicians with regard to improving cognitive health for individuals with serious mental illness. If any of you do this in your role, I'm sure that the research and clinical manuals that Dr. Medalia has developed over the years here probably serve as foundational text for you in the things that you are doing. And we'll do a little plug that she also directs the Cognitive Rehabilitation Conference every year here, which is really the preeminent conference for cognitive rehabilitation and psychiatry here. And that, I believe, is actually coming up this summer here. So if anyone is interested and has not yet registered, make sure to look for that. I can tell you that it is one of the more enjoyable conferences that I've had the opportunity to attend. But more importantly, I'm looking forward to turning things over to our distinguished speaker today, Dr. Medalia. As always, we'll have a Q&A at the end of the session today. People can submit their questions in the chat, and we will answer those at the end of Dr. Medalia's presentation. So with that, I'll turn it over finally to our distinguished speaker, Dr. Alice Medalia.
Thank you, Nick. What a lovely introduction. And it's such a pleasure to be here virtually, and I did scroll down and see your name. So I really look forward to the question and answer period afterward and hearing from all of you. But I'll start by telling you a bit about what I've been doing and thinking about, and we'll move forward. So, and if for some reason sound isn't working, or somebody wave at me or tell me, okay. So I'm going to be focusing on cognitive skills training, particularly for people who have psychosis. And now we have, oh, I see. Okay. So, and the goal of focusing on cognition is really, it's the same goal as for all aspects of mental health treatment, which is to focus on functioning, to help people be able to do the things they want to do and to be able to function at their best. And so usually for many people, they're very concerned about their ability to work and to socialize and maintain their home and to be at school. Those are some of the key aspects of functioning for many people that they want us to help them with. So cognitive impairment is unfortunately, it's one of the symptoms of psychosis, and so it's a problem for many people who have a disorder that causes psychosis. And that kind of cognitive impairment can make it really difficult for people to function in the roles that they value. And I am going to just show you a little bit of people talking about that.
I'm not doing great in school, but it's not because I don't try. I just have trouble keeping up. When the teacher is talking, I just want to say, slow down, it's a lot, and I can't keep up.
Welcome to Cognitive Health Solutions.
I really want to get a job, stay clean. You know, I was just in jail, and people don't think I'm really reliable. I need to get my GED. It's hard for me to stick to things. You know, I get bored. I lose focus. I think if I could focus, I could really turn my life around.
I miss school, my friends, playing volleyball, stuff like that. But at the same time, the thought of going back is scary too. Some days I can't even leave the house. My parents don't think I'm ready because I struggle with remembering things, with sticking to a schedule and stuff. I love my family. I want to make them proud.
I hope you could hear those people talking about what it's like to have cognitive problems. So as, for us, people who are mental health professionals, there are a number of ways that we can address cognitive health. And I think perhaps the most fundamental way is to have the whole concept of cognitive health be really embedded in our, what I call the vocabulary of recovery. So that it's just something that we're comfortable thinking about and looking at and considering and talking about with others. And when cognitive health is just always there and as something that we're going to consider, I think that immediately that means that people will more readily address it if there is a problem. But there are very specific services that we can offer people who are struggling with cognition. One way to help is to provide education, to explain about cognition. And I think in that regard, it's really important to explain how there's every reason to be hopeful that somebody could actually improve their cognitive skills, because cognition is something that is malleable, that we can improve. So a lot of times it's helpful to provide education so that everybody is thinking about cognitive health. Sometimes it's important to give an assessment so that you can identify what are the strengths and what are the weaknesses. And those assessments can range from self-report to hearing from others to formal testing. And when there's formal testing, and by that I mean giving, for example, tests of memory or attention, there's a whole range of options there too, from relatively brief screenings to more lengthier assessments. And so there's a lot of choice, and one can pair the type of assessment with what's needed. Another way we can address cognitive health is to provide what I call liaison services. So for example, if somebody is at school and they are having trouble with paying attention and processing speed, maybe they would be helped by getting extra time on tests or to do their work. So one way we can help is to make sure people are getting the services in the particular settings where they're functioning. And then we also can provide very specific treatments to improve cognition. And I'm going to be talking a lot about that today. And that cognitive remediation is, of course, an example of that. When we are addressing cognition, really the goal is to enable recovery. And so all the services that we provide are something that one would arrive at providing that service really as a result of discussions with somebody about what would be helpful for them. And in those discussions, of course, we want to be empowering the individual to feel like this is something that a course of action that we will help them with, but it is ultimately something that they are choosing. And so it's a collaborative process. And cognitive remediation is a recovery-oriented service. It should be strengths-based. and patient-centered. And the goal is really to improve cognitive health so people are functioning at their best. All of the cognitive health interventions involve learning. You have to learn about what cognition is, what the cognitive skills are. There's learning to improve a particular skill. If you're going to focus on memory or attention, then you are learning to have better attention or memory. And also another way that we learn is just learning the supports that will help our cognition, or learning about the ways we can conduct our lives so that we are at our cognitive best. So if one is learning about how sleep impacts cognition, or how exercise impacts cognition, those are also examples of how learning is involved in the various cognitive health interventions. So when we are learning, the process that underlies that is called neuroplasticity. Some people call it brain plasticity or brain malleability. It is the ability of our brain to form and reorganize the synaptic connections, and that happens in response to learning or experiences. And it also happens if there's been injury to the brain, then there can become a process of reorganization. Neuroplasticity exists at all ages, so it doesn't stop at a certain age, which is a good thing. And it's the process of neuroplasticity really underlies learning, and it gives us hope that anybody with a condition that is impacting cognition can actually make improvements in their skills. Learning also requires motivation. And so in order to learn something, you have to be motivated to do that. And motivation is often diminished in people who are experiencing psychosis, so that a person who experiences psychosis may find that they are less motivated to do the things that they used to enjoy or that they do enjoy, and that they're just not initiating or sustaining activities. We often see how cognition and motivation interact to impact behavior. And here's an example of that. If psychosis, schizophrenia can really impact people's motivation. So if somebody starts having difficulty initiating a behavior to do something they value even, then what happens is they're no longer putting themselves in situations where they can develop competencies. So somebody may find that they're not going to school, or they're not getting out and socializing, or they're not getting out and working. And when we go to school, when we socialize, and when we work, we're constantly learning and developing competencies at it. But so if you're not getting out there and doing those things, you're not developing competencies, and you start to sort of fall behind and expect that you won't be good at it because now you're lagging. And that expectancy of failure, unfortunately, is one of the biggest predictors of why people then start to withdraw even more and have difficulty initiating. So that's a vicious cycle it's a very negative cycle that we often see in people who are experiencing psychosis. When we try to address cognitive skills, it's really important to appreciate the role of motivation. It used to be that when people thought about learning or training somebody on any skill, the model, what most people would think about is, well, you have your ability, you give them exercises, and they learn. It's kind of called an aptitude instruction interaction. So it's, you know, in that old model, depending on someone's ability, if they do enough drill and practice, they'll learn. But what has been increasingly recognized is it's not simply that ability and amount of drill and practice affects learning, but people's motivation also does. And motivation interacts with the amount of learning and with the instructional techniques that that are offered. So if somebody is motivated and they have the ability and they're doing the exercises and they're getting the instructional techniques to help them improve, they're much more likely to learn. This has a lot of implications for how we approach treating cognitive impairment. So in the old model, if you just think about it, you know, well, it's your ability and practicing, then you would just give people drill and practice exercises to help them improve their cognition. But knowing how important motivation is, we can now also focus a lot on the instructional style and the ways that we actually design our treatments so that it isn't just drill and practice, but that there are embedded into our instruction motivational enhancements. There's a lot that's being written about motivation and learning. And what's really interesting is that the shift has really come to thinking about motivation as a reflection of someone's values and autonomous volition. And that's really interesting. Look at the titles of some of these books: Collaborative Learner Autonomy, Autonomous Learning in the Workplace, Self-Regulated Learners, Self-Motivated Learners. So people who study motivation and learning are really focusing a lot these days on how learning is a reflection of what someone values and of their autonomous volition. So I'm going to talk a bit more about that. Autonomous learning implies that somebody understands and endorses the objectives of the learning activity, so that they are engaging in that learning activity, understanding what it's about, what the objectives are, and that they value and are willingly engaging in the opportunity. It also means that they have a real interest in learning. It's helpful to also consider what autonomous learning is not. So autonomous learning doesn't mean that somebody comes into a cognitive skills training activity session and just does whatever they want. Instead, it would mean that somebody comes in, there's been a process of discussion identifying how cognition is getting in the way of their goals and the way they want to function. And there's been discussion about what might be helpful, and an agreement, for example, that focusing on memory may be useful to them in terms of their goals at school or at work. So autonomous learning also doesn't mean that you don't get any guidance and that you're completely independent. You can be autonomous and yet be dependent in some way, and most of us are, right? I am quite dependent on people to help me a lot with technology. But that doesn't mean I'm not an autonomous learner. So one of the things we think about as we design learning environments is how to promote autonomous learning. Brett Jones is an educational psychologist who put together what he calls the music model of motivation. And I think it's a very easy and helpful model to use when you think about creating motivating environments. The music model puts motivational strategies into 5 categories. It's based on theory, but you don't have to understand or know all the theory to use it. You just need to sort of know what people consider as useful to get somebody engaged and motivated. So the purpose of the model was to give instructors a framework for designing their learning activities so that they would be motivating to others. And in the context of what we do as clinicians, that would mean, and I'll kind of go through the various steps of it. The M in music stands for empowerment. So what that means is that when we're creating a learning activity or a space for learning or for improving cognitive skills, we would want the person to feel like they have control over some aspect of their learning. In other words, they're not coming into a situation and being told what to do. Instead, they're coming into a situation that they have some control over. It's important that a person understand why they're learning what they're doing. Why are they doing this particular attention exercise or memory exercise? How will it be useful to them in doing the things they value? Another key element is making sure that when people are working on activities, they have an experience of success. Because when people feel competent and successful and likely to succeed, they're likely to put in more effort. We all know that. Nobody likes to go into situations where you feel you're going to fail, right? We are much more comfortable doing things where we think we have some chance of being successful. Another key element, the I part of music, is interest. So you want to try to have activities that people will be interested in and to find engaging and maybe even fun. And the last part, the C, means that we create a learning environment where people feel like they are valued as a person and cared for, where the interpersonal relationships are experienced in a positive way. So that's kind of the way the music model works. And so the idea would be that a clinician creates this learning environment. The person, if we're talking about cognitive remediation, cognitive skills training, the person would then be coming into a space where they feel like they have control, where the activities are useful to them, where they feel like they can be successful and the activities are interesting and the interpersonal experiences are positive. And that might make them be more engaged and focused, and then they learn more. And as a result of their learning more, their skills start to improve, and other people see that as well. So we actually had a study that looked at whether that music model would be useful in a cognitive remediation program. And we asked people who were doing randomized controlled trials of cognitive remediation to have their participants complete a scale assessing, it's called the music scale, assessing whether their experience sort of met those different criteria. And what we found is that, in fact, the people who rated the learning environment as more motivating did attend with greater intensity. So that's a good sign. It really means it's a sign of that linkage between when people are motivated, how they do engage more in their environment. There are a number of things we can do to create a learning environment that promotes autonomous learning. And here's some examples of things a clinician can do. One is to use shared decision-making about what the focus of learning should be. That means when somebody is coming into a session, to review with them what is it that they're working on and how is that useful to them in their everyday life, and what are the specific exercises that would be helpful today. To give somebody autonomy, one of the key ways to give people control in an experience is to give them choice, and to give them meaningful choices. And there's an art to doing that. Obviously, if you're giving too many choices, that could be overwhelming. If you give somebody no choices, then they lose control. So, so giving somebody a choice of, say, there are these two activities that might be helpful for you to improve your processing speed. Right there, you're giving someone some control if they can choose which one they want to start with, for example. In our interactions with people, we can be really mindful of how we use language to promote autonomy, and we can minimize controlling language, minimize saying things like you should or you have to, and instead use language that is considerate of that person's autonomy. And when we find that people are engaging in behaviors that perhaps are disruptive to group process or difficult, that we provide a rationale for why we're asking somebody to change their behavior. So those are examples of ways that we can promote autonomous learning. What about the ways that we could maybe promote value in learning? So remember in the music model, it says that when people consider a task useful, they're more likely to want to engage with it. So when you think of something as useful, you're valuing it. That's a way of valuing it. Also, when you think something's fun, that's a way of valuing it. So what can we do to support the value of learning? Well, one thing we can do is try to make sure we're using tasks that are interesting and enjoyable. And there's so many tasks out there these days, and there's a whole range of cognitive training activities available to use. And so one of the ways that we can promote value is just by being thoughtful in terms of choosing activities that people find interesting. And then we can also link the activity to what it is that person values doing or the kind of person they want to be. So in our discussions with them, when we say, well, when you're doing this, how do you think that's helpful to you? We can make explicit linkages between the task and the value to them personally. So there's research to support that, and here's some examples of that. We have unpublished data from a study we did publish. We didn't put out this particular side of it. We asked people to rate the value of the various computerized exercises they were doing, and we found that that was a predictor, actually, of the change in their cognition as a result of treatment. So that when people who came into the treatment valuing it more tended to make more change. People who saw tasks as useful, and this was in a published study, tended to attend sessions more regularly, and therefore achieve
Hi, all. Sorry, I think we may have lost Dr. Medalia there. Um, Hopefully, she'll jump back on here in just a second. Oh, looks like she may be doing that now.
Hello, can you hear me?
Hi, we can hear you now.
Okay, when did you lose me?
Maybe just about a minute ago. It was
Okay,
very recent.
all right. Let me go back.
You were on the slide where you were showing some of the quotes from and findings from studies you've done around motivation and
Okay,
participation in remediation.
thank you. Does that look about right?
That's the one. And in fact, someone from the audience was kind enough to say the last thing you had just said was people who saw task as useful tended to attend sessions more regularly.
Super. Thank you. I appreciate that guidance as to where I was. So that probably was on the study by Saperstein. So in a different study, they found that people who actually completed the treatment were more likely to show an increase in an interest in value than those who didn't. And a study by Bryce found that baseline reports of the value of the activity in the program were the only significant predictor of attendance, even when they looked at baseline cognition and symptomatology. So the odds of reliable improvement in cognition increased significantly with greater improvements in program interest and value. So there's research really supporting the role of value as a motivator and for change in cognition. In the music model, one of the other key areas is success. And so what can we do to create an environment where people feel competent and where they feel they'll be successful? I'd say, one of the most important things we can do is make sure that the difficulty level of the task has been set appropriately. And I find that that's actually something that when people start out in cognitive skills training is not necessarily something they're good at. I often see people coming in and they're setting the difficulty level way too high, and then getting really frustrated, or they may come in, start out treatment, and they're setting that difficulty level really low, and they're really uncomfortable making change to go to a higher level. So I think there's a real role for the clinician in terms of helping people find that sweet spot where they will be challenged but still feel competent and can have an expectation of success. So there are other ways that we can promote that feeling of competence. You can emphasize a strategy. You can talk to people and give them coaching and emphasize strategy. And we also do a fair amount of work in our groups, actually addressing cognitive errors and using a CBT approach, where we talk about some of the beliefs that people have about cognition and about thinking errors. And we talk about negative self-efficacy beliefs and ways to challenge those beliefs. So those are all things we can do within the context of cognitive remediation to promote a sense of competence and to promote expectation of success. This is something I think is really important, because when people don't expect that they'll be successful, they tend to drop out pretty quickly and not be very happy with the treatment. So when, on the other hand, when people feel like they can be successful, they tend to get engaged and choose a wider diversity of tasks and put forth more effort. They persist longer at tasks, There's a lot of research actually showing that when people feel like they'll be successful, they actually learn more. Some of the research supporting this, there's research supporting the role of perceived competency for engagement. So expectation of success has been associated with intensity of attendance to cognitive remediation. It's also been associated, baseline expectations of success has been found to predict how long people will persist on learning, and even at 3-month follow-up. So that was a study by Choi et al. We went backwards there. And then in the music model, they talk about caring, and that's that interpersonal component, the relationship between people in the group and between the clinician and the participant and any given participant. So there are lots of things we can do to promote that. We can convey respect for the individual. We want to take every opportunity to help each person feel valued and significant, convey concern when they're facing challenges, but also convey an expectation that they're going to be hopeful, and expectations that they will sort it out. I think creating a warm and fun atmosphere, an atmosphere that promotes a sense of inclusion, is really important. Also to provide opportunities for each person to give, not just to receive, because most people feel better when they're also giving, not just being a recipient. There's actually research supporting the impact of relatedness, to studies showing that the relationship with the therapist is really important. Therapeutic alliance was associated with greater cognitive and functional gain in one study. And in another study, people who rated the alliance more favorably were more likely to improve on their target cognitive complaint. And the role of peers has also been studied in research. So people working with a peer showed more cognitive gains than when they worked individually. And I have a quote here from somebody in one of my groups who I said, why do you come to the groups? What is it you value? And she said, I come here for the socializing. So that was paramount for that one individual. So, putting all this together, I think when we are designing cognitive remediation programs, we really want to be thinking about how we can help each individual feel like they have a choice in engaging, that it's their decision, to help promote the value of learning, and to help people feel like they'll be competent at what they do, and that the relationships that they encounter are going to be positive. I'm going to shift a little bit in this last few, part of the talk, and just try to address some of the questions I most frequently get about cognitive remediation. I call it the who, how, and what. That's what we're going to do now. The first question I often get is, do we have to call it cognitive remediation? And the answer to that unequivocally is you absolutely do not. I think calling it cognitive remediation is not very client friendly. And when I ask participants, what would you like to name this group? These are some of the names that people have come up with: Learning Center, Brain Gym, Thinking Well, Cog Skills. So I think an emphasis on the positive, on the cognitive health, is something that's going to make for somebody more likely to want to engage. A lot of people say, yeah, but what actually goes on in a cognitive remediation group? So let me show you what an example of that.
Recovery is possible. I feel better about myself.
It gives me hope.
I'm happy.
It's the support and the friendship.
I look forward to each day.
It's just a great resource to have. I think the Thinking Well program has helped him a lot. Plus, I see he's a little bit more focused. He remembers things. It has really made a big difference.
Even after symptoms of mental illness have been treated and controlled, certain levels of cognitive impairment interfere with daily life. At Laurel House, our Thinking Well program is addressing that with working on all-around wellness and improving cognition.
Thinking well starts with a technique called cognitive remediation. So you have two things to pay attention to. One is the menu, right?
Good job.
This part of the program centers on computer-based drills that help people practice and improve their thinking skills in areas like memory, attention, problem solving. Thinking well is basically a fitness program for the brain.
It gives your brain a workout.
What cognitive skill were you using?
Then we follow up with additional cognitive training that helps people apply those skills to real-life situations.
I get lost because I've been on the computer and I've been chatting away and I have trouble paying what? Yeah.
I think because of Laurel House and of the Thinking Well program, something triggered in him that he said, no, I have to get my health together. So it has made a huge, huge difference in Shoel's life, in our life.
So that gives you an idea about what actually might happen in a cognitive skills training session. Another question I get asked, well, let me just say that I want to highlight that video is produced by a place called Laurel House, which is in Stamford, Connecticut. And they have a very active program that they call Thinking Well. So another common question I get is who's the best person to refer for this service? Who should we be suggesting go to cognitive remediation? So it's helpful to look at the research base, and the research on cognitive remediation in schizophrenia is typically done with people who are between the ages of 18 and 65. And they have a psychiatric diagnosis. And I should actually say now there's a lot of research coming out also on affective disorders. So there's really a nice research base for not just schizophrenia, but also the affective disorders. And then you see it as well in other psychiatric disorders. There's a research base, for example, in ADHD. Most of these studies are done with people who have an IQ over 70. I think that's really important because when someone's IQ is less than 70, there isn't a strong research base that this particular approach is going to be useful to them. And on the other hand, there is research showing other approaches that might be useful. So when someone's IQ is less than 70, I think it's a good time to be looking at the approaches that are more likely to be helpful to them, to that group of people. Usually people have greater than a 4th grade reading level and no substance dependence. And here I want to really emphasize that saying dependence, that doesn't mean use. A lot, people are still allowed in the studies if there's use, but most studies rule out people who have a diagnosis of substance dependence. And another rule out for most of the research is recent head trauma. So those are the people that are usually in these studies. And so when you're thinking about referring someone, that's a good, those are some good guidelines just as a start, And then the second guideline is to ask the person, what is it that you want to be accomplishing in the next couple months or weeks? What is it that you're really thinking about is important for you right now? And would having better cognition help you meet that goal? And I want to emphasize here that question is framed, in positive terms. It's not, do you have cognitive impairments? But would having better cognition help you meet that goal is a more positive framework for entering into those discussions. So if somebody identifies it, having better cognitive skills would be helpful to them, and they're in those, 18 to 65 and those other criteria that I was mentioning, those would be examples of people you should really be thinking about as referring. I think it's always helpful to think about a person so you can conjure up an image of someone. This is a person who was in school, had major depression. Their grades went way down. And they dropped out of school and so they could focus on treatment for depression. And the treatment was really helpful for improving their mood, but did nothing to address their cognitive problems, which persisted even when their mood got better. And so the person went back to school. Their mood was better, but then they still couldn't concentrate and pay attention the way they needed to do well in school. And their grades, they were having trouble with their work. Grades went down. That caused them to feel depressed. And then they dropped out of school again. So that's a downward spiral, and it's sort of an example of when things can really go wrong when we don't address cognition. Another question I get is, does it help? And there's a lot of research, a lot of randomized controlled trials, a lot of work being done to answer that question of whether cognitive remediation is helpful in schizophrenia and depression. And there, across the studies, the research does support the use of this treatment, okay, in adults at various ages. And the research suggests that it can really help people improve not only their cognition, but their functioning. And the research also suggests that cognitive skills training can pair well with other recovery-oriented treatments, and that when we address cognitive health, you can actually see changes in brain physiology, and you can see positive therapeutic outcomes. Here's someone talking about their experience with cognitive skills training. This is again from the Laurel House group.
Steve recently came to Laurel House suffering from anxiety and fear of socialization. He joined the Thinking Well program and noticed immediate improvement.
I felt like, in my head at least, that I had more social skills than people were giving me credit for. And Thinking Well has really proven to me that, yeah, I do have those skills. When you do brain exercises, you definitely see, well, basically you see more clearly. It really sharpens all your thinking skills. These will translate out into pretty much any aspect of your life. Navigating traffic, navigating a grocery store, it just improves your overall skills in navigating life, essentially. I guess
So I think it's always helpful to get a personal perspective and not just from the research. So that's why I wanted to include that clip of Steve talking. So we've covered a lot of territory, but kind of to sum it up, as we look at a picture of a cozy cognitive skills training group, cozy in the sense that there are a lot of people working closely together, and I'm looking at that and thinking, goodness, in this age of COVID where we have to have social distancing, that can't happen right now. But what have I talked about? I've talked about how cognitive skills training really addresses cognitive health so that people can find it easier to function in their everyday life and goals, and that the importance of addressing not just cognition alone, but motivation, because when people are more engaged and when they value the treatment and feel empowered, then the outcomes seem to be better. And that ultimately cognitive remediation is a recovery-oriented service. I wanted to end by just saying that it's been one of my goals to try to make it easy for anyone who wants to do cognitive remediation, whether they're as a clinician or participating in receiving it, to try to make it more accessible for everyone. And to that end, we have books, training manuals. There's a website called Teach Recovery, lectures, and there's also there's on the web for free a handbook. There's the conference that's coming up June 4th. I really hope you'll come to that as well. So we're always trying to put out more information to make it easier for people to learn about cognitive health and how we can address it. And I think I'm better end there so we have time for questions.
Thank you, Dr. Medalia, for a wonderful presentation. We've had a number of questions already come in, but people can still submit those in the chat to me here. The first question is, when setting up a cognitive remediation lab, would you face the computer working stations to face each other to make it more inclusive and social, even though it may lead to decreases in concentration?
That's such a great question. There are different ways to set it up. I think in that video that you saw, they at the Thinking Well program at Laurel House, they have set up their program almost like classroom style, where there are these desks and people are, and then when there's a group discussion, they sort of, the desks are on wheels, and then there's a little bit more, they push them aside a little bit and people sit around. So I guess my quick answer is that I've seen people set it up in different ways. My own programs that I set up, we usually have the computers on the perimeter. So when people are working, their backs are to each other. And then when there's time for discussion, everyone turns around and there's a circle. To some extent, the way you do things depends on the space you have available. I know some places there's a conference room with a table and laptops, and everybody sits around the table with laptops and works. And people have said that seems to be fine also. Some of this is you need to know who you're working with and what will be best for them. People really vary. Some people are very sensitive to distraction and others aren't. So I don't think there's any one answer. I think you have to be, flexible in terms of what space you have available and thinking about your particular clients.
The next question that came in is, are cognitive-based drills essential? What about identifying cognitive skills and practicing within a functional activity?
Yeah, so I guess there's a little bit of research on that, and I guess to some if I speak to you as a clinician and not as a researcher, I would say the first thing is to figure out. I'm always looking for the least invasive way to help somebody, right? I want to minimize how much time they spend with mental health professionals. So if you think that, going back to school is going to give somebody sufficient cognitive exercise that it will make a difference, you could certainly try it. But there is research to support that there's certainly a group of people where that's not going to work, for some people, having the specific cognitive exercise is essential. So the answer to that question is there's definitely a group of people for whom it is essential, but there may be other people where it's not.
The next question was in reference to when you were talking about exclusion criteria for studies of cognitive remediation done to date, largely among people with mental illnesses. And you noted that head trauma is typically an exclusion criteria. The question is, recognizing that these people have been excluded from these studies, is cognitive remediation useful for people with head trauma?
Oh, yes, there's a lot of research on that. So yes, actually, cognitive remediation for people with psychiatric disorders we learned a lot from the people working with those who've had head injury. So there's, I think the reason it's excluded in the psychiatric research is that the approaches are different and the needs are different. So people who have head injury, for example, one of the most common impairments is in naming, which is it's really not an issue for people with psychiatric problems. So the cognitive deficits are different and the approaches that are used are different. So I think that's a reason why you see the cognitive remediation programs for people with head injury not accepting people with psychiatric problems and vice versa.
The next question that came in is, are there any free computer-based drill programs?
Oh, yes, there are. Absolutely. Yep. And there are always new ones. I mean, I can't begin to, if you spend time on the web, and there's some programs that maybe they're not free, but they're very reasonable.
And the next question is, how are you modifying cognitive remediation during COVID?
Well, yeah, that's a great question. So we do cognitive remediation virtually. We run the groups virtually on Zoom. And I was just running a group before I came to do this. So what happens is on Zoom, you set so that everyone can share their screen. And then people log on to whatever cognitive exercises they're working on, and they have their computer set so that the clinician can see their screen, and then you just click from person to person. You can see what they're doing, and then we have a group discussion at some point. So cognitive remediation can be done virtually. It can also be done hybrid with some people in the room and some people not in the room.
Okay, I think we have time to squeeze in one last question here. This one is, billing for cognitive remediation is a challenge in my clinic. Do you have suggestions for how this service can be reimbursed?
Yeah, so that really depends on the clinic. And how they do their billing. But most places it's either fee for service or bundled rates. If it's fee for service, then the cognitive remediation would be, I guess, considered a cognitive therapy, or so you would just bill for it like any group therapy. But that it would only be reasonable if you actually do that bridging discussion. And then if the clinic is doing bundled rates, then there would need to be recognition that the cognitive remediation is one of the services that's provided. So in New York State, for example, it is a recognized service for the bundled rates.
Well, Dr. Medalia, thank you for a wonderful presentation today. And thanks everyone for joining us. We hope everyone is staying well and that you'll be able to join us next week when we have Dr. Carrie Bearden, who'll be talking about progression to psychosis and pathways to psychosis among people at genetic high risk for psychotic disorders. So take care, and thank you again, Dr. Medalia, for a wonderful presentation today.
Yep, it's a pleasure seeing everyone.